Let's now move on to our third speaker, Marjan Biria, who is supervised by Trevor Robbins.
Thank you, Peter. So it's a pleasure to introduce Marjan Biria, who's in the 4th year of her PhD. In fact, she's due to submit on May the 1st. And in addition, just to put a little more stress on this, she is due to take up a postdoctoral place following her thesis. And we think that this is going to be the first step of a very promising research career. Now, as you know, collecting in-person data, behavioral and neural, in difficult psychiatric groups has proved to be very challenging in the last couple of years. Marjan has risen to this challenge, and she's going to present some of the highlights of her recent findings, which I think you'll find very interesting and we think are highly publishable. Thank you.
Thank you so much, Trevor, for the introduction. So I'm going to share my slides. Can everyone see my slides? Okay, great. So my PhD work was on understanding the neurobiological mechanism of obsessive compulsive symptoms in schizophrenia patients caused by their medication clozapine. So about 25% of patients with schizophrenia, they are also diagnosed with comorbid OCD. And unfortunately, these patients, they tend to have a reduced social functioning, a higher suicidal risk. And in our 2019 paper, we actually reported that these patients have a higher positive and depressive symptoms. But besides the comorbid OCD, we have the drug-induced obsessive compulsive symptoms. And by far, the highest rates have been reported for clozapine. And this works possibly through the serotonin receptor antagonism. But in a more recent publication, we also reported that these symptoms, they impact patients' well-being, and this is independent from their schizophrenia symptoms. Despite the importance of this comorbidity, there haven't been many studies on the topic, and that's why I decided to study these patients during my PhD. But in this talk, I'm going to be focusing on checking, which appears to be one of the most common obsessive compulsive symptoms. And my initial work around this revolved around revising a new laboratory task to measure checking behavior. So we have tested around 100 participants for this study, divided into 4 groups of healthy volunteers, OCD, and 2 schizophrenia groups. They were both treated with clozapine. One group showed obsessive compulsive symptoms after the treatment, whereas the other one did not. And I did describe the checking task in my previous talk, and it is on YouTube. But very briefly, participants get to see 2 images, and they have to decide if these 2 images are the same or different. And they have the chance to check the images again to improve their answers. And when we look at the performance of all 4 groups, it is very clear in healthy volunteers that they didn't need checking to improve their performance because they were already performing very well. Whereas the 3 patient groups, they needed checking to improve the performance or accuracy of their answers. And it is very important, very interesting to note that only the schizo-OCS group amongst the 3 did not use the checking information to improve their accuracy. So they showed dysfunctional checking. And this dysfunctional checking, it was also correlated with their clozapine dose, but also executive functioning, such as a special working memory performance. And this is despite the fact that both schizophrenia groups, they were matched on these factors. So we were also interested to know more about the neural mechanism of these symptoms. And anterior cingulate cortex is a very important region for OCD, as previously shown. It is implicated in error correction, which is obviously very relevant for checking and in goal-directed behavior. But ACC is also an important region in schizophrenia. And thank you so much, Samuel, for the very nice introduction on inhibitory signaling. So there are studies showing reduced GABA levels in ACC of schizophrenia patients, and the effectiveness of medication being associated with GABA increase in ACC. And during my master's, I also found enhanced ACC activity in patients with a high genetic risk for schizophrenia. So it is very clear that ACC is a very important region to study, not only in OCD, but also in schizophrenia patients. And that is why we decided to study the neurometabolite ratios in ACC. Again, thank you, Samuel, for making this easier for me. We hypothesized finding higher glutamate, which is the main excitatory neurotransmitter in ACC, and lower GABA, which is the main inhibitory neurotransmitter. And we also hypothesized that these concentrations would be linked to obsessive compulsive symptoms. So this is just to show you the region that we were interested in. So this is the ACC region that we were interested in. And this is what we get to see after we acquire the data. So this line that you see here, it combines all the neurometabolites in that area together. And depending on the concentration of neurometabolites, their peaks will be higher or smaller. And unfortunately, the neurometabolites that we are interested in that are important for schizophrenia and OCD, such as GABA, glutamate, and glutamine, they have a much lower concentration. That is why their peaks are concealed or hidden underneath the metabolites with a larger peak, such as these ones. And in a recent review, I also found that GABA, glutamate, and glutamine, they have been very challenging to study in OCD using more conventional magnetic resonance spectroscopy methods with a lower resolution, usually ranging between 1 to 3 Tesla. And that is why we decided to use a 70 scanner to study the neural correlates of obsessive compulsive symptoms, because this enables us to dissociate these neurometabolites from each other. Because in most of the studies with a lower resolution of their magnet, they combine these neurometabolites so that it is easier to detect them. But with a 70 scanner, we can actually dissociate them and report them individually. So in the beginning, we aimed to test all 4 groups on the 70 scanner, but then the pandemic started and the recruitment was very challenging for all participants, but then especially for patients and especially for schizophrenia patients. And that's why we could not test schizophrenia patients on the 70 scanner. However, we did continue the study with OCD patients and healthy volunteers. And I'm going to show you some very exciting results. We actually confirmed our hypothesis of lower GABA and higher glutamate in ACC of OCD patients. And when we combine these neurometabolites to GABA to glutamate ratio, we can see that the difference between OCD and healthy volunteers is very large. And in addition to finding these differences in neurometabolites, their concentrations were also associated with behavioral performance, including the dysfunctional checking, but also a bias towards habitual over goal-directed behavior. And to measure the latter, we used a contingency degradation task, which basically manipulates the relationship between actions and their outcomes or consequences by degrading or uncoupling them. And persistent behavior is seen as a bias towards habitual rather than goal-directed responding. And what you can see on this slide, on the y-axis is the difference between habitual and goal-directed degradation. And on the x-axis, you can see the GABA to glutamate ratios in ACC and GABA ratios in ACC. And these positive relationships, they were found only in OCD patients, not in healthy volunteers. So what these findings suggest is that ACC is not only implicated in checking, but also in adjusting the balance between goal-directed and habitual behavior. But they also suggest that checking is a consequence of excessive habitual behavior. So to summarize, only schizo-OCS group showed dysfunctional checking, and this behavior was correlated with deficits in special working memory, but also their clozapine dose. And this was despite the fact that both schizophrenia groups showed similar executive functioning deficits, such as special working memory, and they had a similar dose of clozapine and the same treatment duration. For our 70th study, we successfully confirmed our hypothesis of higher glutamate, lower GABA, and GABA to glutamate ratios in ACC of OCD patients. And these neurometabolites, they were also implicated in dysfunctional checking and habitual behavior in OCD patients. And of course, the question still remains whether we would find the same neural deficits in the schizo-OCS patients. The answer is maybe, but in order to be able to answer this question with a high certainty, we do need a 70 study in these patients. I would like to thank my supervisor for always being there for me, no matter how busy he is, and my co-supervisors, especially Dr. Fernandez, who also helped us with the recruitment of schizophrenia patients, and our collaborator, Professor Ed Bullmore, and of course, Mental Health Research UK for supporting this PhD. And without your support, none of this would be possible. So thank you so much.
Great. Well, thank you very much, Marjan. Another super talk. Amazing to see, I think, results at all from 7T. But yes, such stunning results, very important.
Thank you.
We've got some questions. Gemma, first of all.
Hi, Maria, congratulations on such a great study. And also to your supervisors. This is really important research. I was wondering if you've also have looked or are planning or looking at whether there's a relationship to the clozapine exposure and the GABA glutamate imbalance, if you would expect there to be some relationship.
That's a very interesting question, but I'm not sure if I can answer this question without doing a 70 study, but especially because both of these schizophrenia patients, they were on clozapine, but not both of them showed the same obsessive compulsive symptoms. And these findings that we find are related to obsessive compulsive symptoms. So for OCS, we do find lower GABA, higher glutamate. Mm-hmm. I suspect that in schizo-OCS patients, we might find the same deficits or the same concentrations of GABA to glutamate. And although there have been findings showing the same deficits in GABA, I suspect that we would find lower GABA concentrations in schizo-OCS group compared to the other schizophrenia group on clozapine.
Thank you. Very
sorry, I do need another 70 study to answer your question.
On the treatment question, you mentioned that doses of clozapine were similar and you thought about it and controlled for it, but were there any other treatment differences in the group with OCD? So were they having their OCD treated with SSRI, for instance?
So I have to check the medications, but I don't think there were differences because many of the schizophrenia patients, they also have depression symptoms if they don't show obsessive compulsive symptoms. So they are being treated for depression. And aripiprazole is another medication that is prescribed to these patients, these schizo-OCS patients, but it is also an antipsychotic medication. So there were also patients in the pure schizophrenia group that did not show the obsessive compulsive symptoms that were being treated with SSRI or aripiprazole. So there were no, I don't think there were differences there, but I do need to check the numbers exactly. But from what I remember, I don't think there were differences there.
Yeah, it might be something that a reviewer would ask. But your answer led me on to another question, which was about whether there are other phenomenological differences between the schizophrenia OCD and schizophrenia non-OCD. So the OCD difference, does that overshadow other phenomenological differences between the two groups? More negative symptoms, for instance, more depression, more anxiety.
Right. So in the beginning, I did talk about our publication in 2019. We found higher positive and depressive symptoms. And actually in this sample, we also replicated the same findings. We found higher positive and depressive symptoms. These patients were more anxious. They showed higher anxiety. But I'm not sure if these findings are have started after clozapine, or if these patients before clozapine treatments were in general more depressed or showed a more severe schizophrenia.
I suppose I'm thinking of alternative reasons for your results. So was it drug differences? No. Was it other phenomenological differences? Probably not. Samuel.
Yeah, great talk, really interesting.
Thank you.
I was just curious about a couple of things. I mean, I was really impressed by your nice small voxel in the ACC at 70. Very nice.
Thank you.
Were you acquiring both? Did you have to edit to get GABA, or like what sequences were you using with the MRS?
No, we didn't. We used semi laser.
Oh, right. Okay.
Yeah.
And you were able to get both GABA and glutamate together in this.
Yeah. Yeah, we could differentiate them in the same voxel. Okay. But we did do 27 pilot scans with different voxel sizes and locations. And then this size and location gave us the best signal. And it was also mostly reported in the literature for the symptoms that we were interested in.
Cool, thanks.
Any other comments or questions? So as Anne-Marie Miller has put in the chat, they were 3 great presentations. So